السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف المرسلين سيدنا محمد صلى الله عليه وسلم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا وزدنا بفضلك علما. I would like to welcome all of you to this webinar in behalf of the Global Performance Management Academy GPMA, الأكاديمية العالمية لإدارة الأداء. My name is Mohammed Mustafa Mahmoud. I am the head of the academic affair of GPMA, and alhamdulillah, for the last maybe 2 or 3 years we have this good tradition of having a webinar almost every week for the last almost 3 years, and this gives us an opportunity to expand our knowledge and connections and get to get up to date in many of the topics related to the curriculum which we teach at GPMA. Let me go to the next slide. Let me just give you a brief introduction. The Global Performance Management Academy has a curriculum which they developed for 10 courses, and the webinars which we invite usually is related to one of these 10 courses. And tonight the webinar is related to course number 3, which is strategic risk management. This roadmap consists of 10 steps. The first 3 steps related to strategy formulation, strategic analysis and formulation, and key performance indicator and risk management. The remaining 7 steps are related to strategy execution. And as you know, most of the strategy fail at the execution phase. Phase number 4 is about governance and alignment. Number 5 is about leading and managing strategy deployment. Number 6 about KPI, data collections, actual measurement. Number 7, data analytics and visualization. Number 8, performance improvement decision tools. Number 9, data-driven performance review meetings. And finally, number 10 is performance reporting. We offer these courses online. And inshallah, this coming Saturday, we have a batch who will start, inshallah, the first 2 courses, and they will get the certification for these 2 courses. And at the end of this presentation, I will give you more details about this, inshallah. Tonight, our guest speaker is Dr. Sahar Khalil Al-Hagrasi, and Dr. Sahar is a consultant at Ministry of Health, and she is a certified professional in healthcare quality and risk management. She's a part-time acting member in Community Participation Department, Director of Health Affairs in Jeddah, Saudi Board of Orthodontics. I don't know if I did it right or not. I'm not a medical doctor, scientist, committee member. So she's a Saudi Board of Family Dentistry Diploma, a scientific committee member, Saudi Board of, I will get it this time, Orthodontics, Program Director in Jeddah Specialty Dental Center at the Ministry of Health. She's a Program Director of Preventive Dentistry Project, Dentist Visit Booklet, sponsored by Director of Health Affairs in Jeddah, CPHRM, CPHQ, Strategic Planner, and KPI Practitioner, Mini MBA, HMP, ISQA Fellowship. MashaAllah, yani she had a whole list, catalog of professional certification. She's a very hard-working and dedicated person. I have knew her during a program in Riyadh, which GPMA offered about 4 months ago in June, and she was studying at this time the first 2 courses here together in Riyadh. At this time, she was telling me about her plan to finish many degrees. Only a few weeks later, she was calling me and sharing with me the copies of the diplomas. She said, I finished this every other day. She's starting something or finishing something. Bismillah, mashallah, very productive person. We are very glad to have her today with us tonight. And I will leave the floor for her. Now it is 9:07. Inshallah, you have about 40 or 45 minutes. And anyone who has a question, please, you can put it in the chat but don't send it to everybody, just send it to the moderator, and inshallah, according to the time available to us, we'll be happy to answer them. If we cannot within the time frame, inshallah, I will make sure to share with Dr. Sahar all the details and the questions so she can have direct communication with you. Dr. Sahar, very welcome. And inshallah, we are all very eager, to listen to you and get informed about risk management in healthcare.
يعطيك العافية دكتور، شكرا لك، وأرحب بكل الحاضرين ويعطيكم العافية، وأشكر الدكتور محمد مصطفى محمود. يعني أنا كان بالنسبة لي حلم إني أقابل حضرتك، يعني كنت أتابع حضرته من 10 سنين على الأوديمي، وسبحان الله أخذت معاه الKPIs من أول، بس لما رحت الكورس اللي هو تابع الأكاديمية حضرتك الGPMA، كانت صراحة يعني فرصة جدا جميلة إني تعرفت على حضرتك فيس تو فيس، وأنا الآن على المنبر معك. يعني هذا يعني أنا ربنا يعني بيحبني وأمي دعيالي صراحة يعني.
الله يبارك فيك يا سيدي.
وطبعا أنت يعني علامة من العلامين اللي أنا يعني كنت من جد أتمنى إني أتعلم على يد حضرتك. الله يكرمك.
العفو يا ستي، الله يبارك فيك. Let me check with the audience if some of them are English speaker, because we did announcement in English. Please write in the chat if there is any English speaker who cannot speak Arabic, so we will just let Dr. Sahar know in case she would like to switch back and forth between Arabic and English.
Okay.
English speaker. Yeah, we started to have English speaker now. Okay. English, please.
Okay. It's okay. Okay, Doctor.
You can share the screen now.
Okay, thank you, Doctor. Assalamu alaikum wa rahmatullahi wa barakatuh. Today we'll talk about risk management process and insurance regulation. Actually, I had the idea to share my information about risk management just maybe 2 months ago. I'm certified in professional healthcare quality management, and once I finished this certificate, I found there is a very huge confirmation about risk. And when I relate this to the insurance, I found there is a very, very, very adherent correlation between the risk and the insurance companies. So nowadays, in the vision of when we are preparing in the Ministry of Health in the vision of 2030, actually, and the health transformation strategy, we found that the risk management processes and the insurance regulation have a very huge role in these steps. I'm one of the persons or the citizen that really I will be glad to visualize, to realize the vision of Saudi Arabia in 2030. And really, I wish to have this glad to be one of the persons that realize this vision. Today, I will talk about the risk management process and insurance regulation. My outline, first of all, I will talk about the history of risk management and why we start to change from the traditional risk management to the enterprise risk management, and what is the difference between them, and what the healthcare transformation strategy will get a benefit from this change. There is a structure of the risk management process and incident reporting process. I will talk about some points in the incident reporting because it is really the cornerstone of the risk management department. We will talk about risk ranking process, and from this point, it is a very important point because from this point we will know the technique that we will use it in risk financing. Either we will transfer the risk or we will retain it, and then finally we will talk about the insurance contract and the process and its regulation and how the risk is affecting our contract with the insurance company. Actually, in the 1970s, we start they start to transfer from the traditional risk management to enterprise risk management, because really there is a huge data about the medical legal issues, and there is they try to, as much as they can, to control of the financial cost, and I mentioned the emotional cost of the families and society and physicians and insurance. Actually, the medical legal issues, it's raised up and it's get published by the IOM, the Institute of Medicine, in the 1970s, actually, that there is from 50,000 to 100,000 persons died per year because of the medical error. And this is really, it's a huge number, and this is in the United States. From this time, they really decide to concentrate in the risk management and start to do something is called FEMIA, which is a failure mood and effect analysis. They get out analyzing all the failure mood in the healthcare and how they can help it as a proactive way in treatment of the risk. Actually, the risk management in healthcare, it is the probability that something undesirable will happen. So this is will affect and the person who is treated in the hospital, and harmed could be happen there. So harm is defined as unintended physical injury resulting from contributed to by medical care that require additional monitoring, treatment, or hospitalization, or that result in deaths. So there is in a categories for the harm. It's starting from category A until category I, but really the one that it's causing a sentinel event or adverse event, which is well known in all the healthcare organizations, it's category E until I, which is causing a temporary harm or permanent harm for the patient, leading to intervention required to sustain the life, or can cause a patient death. So to know really about this, we have to know the events classification, and what is the event that we have to take care about it, and have a precautions and the proactive methods to treat those events without avoiding the patient complaint, and with avoiding the other complication that can cause financial loss of the organization. The risk in the healthcare, as we say, that it's a probability that something undesirable will happen, and this is the event when it's happened can called adverse patient occurrence or adverse event. So it is unexpected, untoward event with actual or potential negative impact on the patient or person. Let's just imagine this: when the nurse dealing with so many patients, and sometimes there is a peak of the treatment, and she have to take care from each patient as he is the only patient, because it is really patient-centered organization. So sometimes medical errors could happen. We can give him the nurse can in an omitted way that she can give a patient medication for other one. So, and this is a medical error, and this is a potentially compensable event that the patient can lawsuit this organization regarding this error. So to know the errors that can happen in the medical field, there is medical errors as a near miss, which is mean that the error it's there, but it's not reaching the patient yet. So I'm in the way to give the patient a wrong medication, but by a challenge, I stopped. I get busy by other things, and then I discover that really it's a wrong medication. Oh, thanks God that the patient didn't take this medication. This is the near miss. While the other thing, adverse event, either preventable or non-preventable. Non-preventable because of the case of the patient, it's in the end stage, so it's non-preventable and nobody can talk about it, because this has happened because of the health situation of the patient, but the preventable one that can be prevented in the healthcare, it's called potential compensable event. And this can result in a lawsuit or a claim based on the degree of the actual or potential impact on the patient. If any medical error happen that can cause patient death, patient disability, temporary or permanent harm to the patient can lawsuit the organization, and this can affect the organization financially and can affect them in their reputation. So risk management has become a quality, a specialty of its own. And really, when I studied the CPHQ, there is an on chapter number 3, it's talking only about the risk management in the healthcare. So it's the process for making and carrying out decisions that will assist in a prevention of adverse consequence and minimize the adverse effect of accidental loss upon an organization. So the traditional risk management, it was in the past, and it was the number one goal. It's for it's to protect financial resources and reputation. That's only the goal of the traditional risk management, and it's getting changed, and it translated, it transitioned to enterprise risk management, which is caring about all everything as to be learning, thinking rather than learning, leading rather than following, global rather than local, open rather than closed, and teamwork rather than autonomy, and consensus rather than opinion, patient-centered rather than provider-centered, and organization-wide rather than departmental-wide. Actually, the change from traditional to enterprise was due to different pressure points, as the regulatory pressures, the transparency that it's required to be in the healthcare system, the reputation, the fraud and abuse, a new healthcare model, and social media. Everything it's now in the social media. So any error it's happened in the medical field, in any hospital, everyone will know it. So we have to take care of this, and we have to put in rules to prevent those harms to be happened in our organization. So, enterprise risk management get defined by ASHRM. ASHRM is the American Society of Risk Management, of Healthcare Risk Management, and it is the organization that it's responsible about the certificate of the CPHRM. It defined the enterprise risk management as it's a holistic, disciplined approach addressing risk from all sources across and beyond the organization, and that would threaten the strategic goal, objective, and affect the organization ability to create the value. What's meaning of the value? The value in the healthcare, it's mean that a quality of care service, a plus outcome over the cost. So when I give the patient a value, I can't depend that I give him only an outcome or only outcome over cost. It have to be a quality of care. There is an equality, and all of those will affect the strategic goal and objectives of the organization. As Dr. Muhammad stated, that it's from the third course of the GPMA organization courses. It's the third one, risk management. So ASHRM defined an enterprise risk management in a comprehensive framework for making risk management decisions which maximize value protection and the creation by managing risk and uncertainty and their connection to total value. So exclusive speculative versus a pure risk. So I have to know each detail that can protect my value and created. So it's a protection for the value and the creating a value, and really managing the uncertainty. okay? So there is no variability, no variations. When we do the control chart in a good organization, having a good risk manager and high quality management department, a very good quality management department, when we do the control chart, there is no variability or no variation between the services that it's given to the patient. So enterprise risk management supported by an organization board, executive management, and C-suites, and medical staff leadership, and the most important person in the healthcare is the frontline staff, because they are the one who's dealing with the patient. And to have a good organization and a good culture, we have to have a fair culture, or something it's called justice culture. Justice culture, it's mean that there is no punishment, but in the same time, we are not accepting reckless behavior. So enterprise risk management will dealing with different risk categories as a strategic, financial, legal and regulatory, operational, human capital, technology, and hazard. And our goal to reduce the uncertainty and the process variability. As I said in the control chart, we're really reducing the process variability and trying as much as we can to go to the Six Sigma philosophy to reduce the variability and to promote patient safety, maximize the return on investment through assets and the preservation and the recognition of actionable risk opportunities. So what is the difference between them? And before 1970 and after 1970, it was reactive, and now we are a proactive. We are dealing before the harm has happened. Assisted preservation, no, here we are a value creation, departmental, we are organization-wide, holistic thinking and system thinking. It was risk mitigation. We are here in risk prevention, and the engagement was in the board and C-suites, while now it's with the clinician and the staff and the front line. So we have 5 steps for making a decision in the process. And first of all, we have to examine and evaluate the risk technique. And later we have to select the best technique to implement and identify, analyzing the organization exposure and implement the selected risk technique, monitoring the technique making and identifying and analyzing the organization exposure to loss. So finally, we have to monitor and we have to identify which one of the risk it's skipped from us. We didn't evaluate it properly, and harm it's happened. From this point, we have to take it over and return it to phase 1. So structure of the risk management process, it's a 2 main category. First of all, identifying and analyzing exposure, and then treat the exposure. So first of all, I have to identify it and know where is the loss. Is it a property? Is it liability? Is it personal? Is it in the net income? And then I try to control it. From the controlling technique, it's risk avoidance, loss prevention, loss reduction, segregation, and contractual transfer. If I can't control it from those techniques, so the risk has happened and harm is there, I have to finance it. So I have to choose a technique to pay for this loss, either a transfer or retention, either to have a contract with other party, it's external party, to take over me in this loss and pay for it. Or I'm a very huge company, I'm very huge organization, I'm not in need to have a contract with other party to deal with this risk. So I retain it and I pay it from my own money. So first of all, risk identification. There is many ways to identify the risk in the healthcare, but always we are trying to be a prospective and a proactive dealing. There is really a classification of the exposure, either liability or personal loss or property or net income, but there is different way, either informal or formal risk identification system. The most important one, the incident reporting. We'll talk a little about the incident reporting at any happening that it's not consistent with the routine care of the particular patient, or an event that is not consistent with the normal operation of particular organization. And incident report are the cornerstone of the healthcare risk management program. Really, we have to do the report about the incident report, and the report should be objective, coded, analyzed, it's trended, and protected from discovery if at all possible. Really, it's very, very confidential, and really this is when we do the incident reporting and we report everything happened in the organization with a justice culture. We really support our team. Before, in the traditional risk management, when there is reporting, everybody gets scared from getting fired from this their job. Nowadays, with the justice culture, there is no punishment, just report, because we want to know the risk. We want to know the error that could happen. We want to know the near miss to solve it as soon as we can. So this will be very advantage for us, but in the same time, as an organization, not accepting a reckless behavior. So an incident reporting should be reported to the risk management, to people need to know, and content of an incident report have to be demographical information, socioeconomical data, facility-related information, description and detail of the incident, and the challenges, written policy and procedure. It's really difficult to write in the policy procedure for the incident reporting, and it gets different from organization to organization. The occurrence reporting and the screening, it's similar to an incident, but it's when I collect 100 files per month and see what's happened in the files, like it's investigation to know if there is any incident report happened or not. The most important things now, we talk about the risk ranking process. The risk ranking process is depending on two factors: the likelihood, or the likelihood, and or the frequency, and the severity or the impact. And I will talk in detail in this. Regarding the likelihood, there is 5 grades from 1 to 5, and each one have a description, and we categorize each one according to each risk, according to those description. And at the same time, for the severity or the impact, it's 5 grades, but for each risk, like financial risk had 5 grades, patient safety has 5 grades, operation have 5 grades, reputation has 5 grades, and finally legal or regulation. And then I will calculate the amount and multiply the likelihood by the impact, and I will have a risk score. The risk score will evaluate it from here. It's either to be greater than 17, it's very risky, or greater than 10, between 10 and 17, it will be the orange color here, which is before the risky. It's high, but it's not very high. And the medium is from 5 to 10, and the low, it's less than 5. So according to this ranking, I have to examine and select and implement of alternative risk treatment. So I try to control this risk and stop the loss from happening, or lessening the severity of the loss. But if I couldn't, so I have to go for the risk financing to pay for those loss. So the risk financing, the risk control, if I can't control it, I will go to the risk financing, either retention or a transfer. Regarding the risk control techniques, either to avoid the risk, and this is the example of an organization wants to open, a healthcare organization wants to open, and the highest risk, the highest risk in the department, the highest risk department is the OB/GYN department. So the organization decide to avoid this risk by not opening an OB/GYN department in their hospital. Or loss prevention, reduce an organization loss by lowering their frequency. So there is OB/GYN department, but we are not accepting the delivery, or there is no delivery, only for follow-up. Or loss reduction, reduce the severity of the loss. The loss has happened, but I have to treat it. Okay, and segregation is separation or duplication of the loss exposure, either to separate it, make it in so many departments rather than in one department. And the contractual or non-insurance transfer, we will see this in the health, in the financial technique, in the retention, not the retention, the transfer technique to company other than the insurance company. So either to do a risk retention or risk transfer, the risk retention have 5 categories. It's current expenses of loss, unfunded loss reserve, funded loss reserve, poured fund, or self-insurance. The current expenses of loss, it's an open account. Anytime there is an harm happened, so I pay from my own money, and its example is the deductible. The deductible, it's an amount of money it's paid for the insurance company before the insurance coverage. The unfunded losses for the small companies, they can just cover the loss of lost items such as dentures, eyeglasses, hearing aids. It's for a small company and it's really unfunded. So the amount of money that it's covering is very low, but the funded loss, it's funded. There is assets, the outcome of the assets or the revenue of the assets, it's covering the taxes and defending the claim cost. The borrowed funds, we are not dealing with it anymore because the company or the organization has to borrow from other organization to pay for the risk. The self-insurance trust is very good, and really the large companies it's self-insured that there is an account for each department, that this account having a money for the risk, paying for any harm happened in this department. But there is lack of a flexibility because of we can't use the account of OB/GYN department with the dental department. While the affiliated and captive insurance, we have a very good example in our society about this. My Clinic and Bupa Insurance Company, it is both of the organization and the insurance company from the same economic family. And we just describe it as the parents and his daughter. The parent is the organization and the daughter is the insurance company. So there is no outside party. The insurance company is covering its organization, which is in the same economic family. So regarding the risk transfer, so I transmit an organization risk to an outside party, and there is could be in non-insurance or insurance or risk retention group. The non-insurance one, such as a contract with one party of either indemnity agreement or hold harmless agreement. The indemnity agreement, it's a company other than the insurance company. It's pay for what's happened, like اللي هو شركات النظافة وشركات الصيانة اللي هو المينتيننس company in the healthcare and the cleaning companies, هذه كلها all of those, it's considered indemnity agreement, and it's just for paying for the risk, but the hold harmless agreement, it's responsible about the financial and for the legal claim also. So this is the difference between both of them. Why the insurance company, it's a system by which the risk is transferred to an insurance company, which reimburses insured for covered loss and they provide for sharing cost of loss among all insured. So an insurance company, it's covering the organization and paying for all the hazard or pills happen, but there is a different type of the insurance, either first party, third party, or health and welfare insurance or financial guarantees. For the first party insurance, it's covering the own property. So it's covering the own property from fire, business interruption. The business interruption is mean when there is an earthquake happened or fire, there is some months, multiple months, it's closed, the organization is closed for renovation. So this 3 months, the revenue in this 3 months, it's not there. So the organization is losing financially. So this is the business interruption meaning. Boiler and machinery for the machine, builder risk, the new when they there is a new building arranged, flood, earthquake, crime, capitation, stop loss, and electronic data processing and media, commercial crime and insurance and employee dishonesty, and automobile collision. Automobile collision, it's about the automobile itself, the cars itself, different than the third party ones, which is the automobile, but it's not collision because the automobile driver himself, is third party, while the automobile itself is one first party. For the third party, it is most probably in the healthcare liability insurance, and it's a provide coverage to a party other than the insured to make that person whole for loss or injury covered by the insured. Involve 3 parties: one who is harmed, the insured who caused the harm or damage, and the insurer. The insurer is the insurance company and the insured is the organization. And one who is harmed, either the employee or the visitor or the patient or the person who is in the organization. So the third party insurance is a medical professional liability, and this is a very, 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 very common in the healthcare. And really weekly, I can see in my organization like 4 or 5 cases from the private, it's medical a professional liability against the private centers, and we have to judge regarding the errors that had happened in those private organizations. So the medical professional liability, it's have the main core in third-party insurance in the healthcare organization. Then the general liability, other things rather than the patient, it's considered general liability. It's mean the visitors, it's mean other people than the patient himself. The umbrella excess and liability, I will talk about it when I talk about the layers of insurance, and the employment practice liability, garage keeper liability, a director and official liability, error and omission, all of those regarding the managers who's managing the healthcare organization, environmental impairment liability, fiduciary liability, even this about the managers, heliport and non-owned aircraft, educational and the child care center. All of this dealing with the behavior of patient and employees in the organization and the visitors and the doctors or the staff. So a type of insurance, the third type is the health and welfare insurance or social benefit. And this is the most important one type of the insurance, the most important, the worker compensation. And the worker compensation, it's really very important for the doctors, especially because, or for the healthcare staff, because really, and sometimes they get affected by a lots of instrument, and they have to be evaluated for worker compensation or payment for this hazard that happened. I'm one of those people. Actually, I had disc displacement. I did the surgery for changing 2 discs in my neck, C5 and C7, and this is because one of the most important point in my history that I'm a dentist. Finally, the financial guarantees or contract guaranteeing performance. And this is like some companies is guarantee the organization that the organization couldn't pay, I will pay. And this is not anymore used nowadays. The most important 3 insurance type, the working compensation, the third party, and the first party. So a risk financing technique, it's an alternative method to commercial insurance for risk transfer. The most important one, the alternative method, is the risk retention group. And this risk retention group, the company had the organization with a member, it's the one who's covering everything and avoiding to transfer anything to other companies as the affiliated and the captive, like the same economic family. So there is a key variable to consider in selecting risk financing technique. When I want to finance the risk, to pay for it, I have to be either retention or a transfer. And this depends on the size and type of the organization, the financial strengths and resource of the organization, the type of risk to be treated, the organization risk taking philosophy, the organization goal and objective, effectiveness of the risk management and loss control program, affect each technique on the organization long-run cost and therefore on its probability. Actually, 1 hour, it's not enough to cover all of those because each of one, it's a special topic alone. But we're hoping that we consider it right now and later on, inshallah, in other lectures, we can discuss each one of them. Actually, the risk management is 5 topics, patient safety and the financing techniques is one of the topics of the 5. And there is a claim litigation and regulatory and the health risk management operation. So why either two? In simple way, to just simplify it and to know the main thing that let you to decide either retention or a transfer, cost certainty and the financial efficiency. If I have a very high cost certainty and low financial efficiency, I will go for the risk transfer. Otherwise, if I have a very low cost certainty and financial efficiency high, I will go for the risk retention. And the risk retention most probably with a very large company like Sulaiman Al-Habib and Faqih and those companies, and the risk transfer, it could be in others, small companies. And could be blended risk transfer and retention. We can use both of them in the same organization. So a risk retention, when there is a predictable layer of loss, while I will go with the risk transfer when there is unpredictable catastrophic loss. So finally, I know now about the risk and the ranking and techniques for paying for this risk. How this risk will affecting the insurance. Actually, I'm doing contract with the insurance company because I'm sure that I have a risk in my organization. So how can I deal with the insurance company? I have to have a contract. This contract have a declaration page, insurance agreement, condition, and exclusions. What is the declaration page of the insurance contract? It is a page having an insured name. Insured name means the organization name, insured activity, and policy limit, premiums that I have to pay it every month, detectable or not detectable, inception date and the expiry date. So though all of this information, it's in the declaration page. So I have to know, I will know everything about the contract from the declaration page. What is the insurance agreement? It's a broad statement about the obligation of the insurance company that have to be doing it. It's obligated to do it in front of the organization. And the conditions, it's defining, it's really the condition is explanation to the insurance agreement. The exclusion is the things that it's not covering it. The insurance agreement and the conditions, it's resembling the goal and objectives. As the goal is a broad statement and the objective it's description or explanation to the goal. So the direct insurance, an insurance contract, there is different insurance level. There is a primary insurance and excess insurance. And remember the umbrella insurance, which I talked just about it in the third party. The primary insurance is the first layer of coverage, the layer that is prone to loss, while the excess insurance, it's sit over a specific primary insurance to afford additional limit of liability, which is mean when there is a first layer, it's gone, okay? So for example, for general and professional liability, I have 50 million a primary layer, but I have, if there is an occasion happened or a harm loss and it cost me 50 million, so the insurance will pay it. Okay, if it's cost me 100 million, what can I do? If I haven't an excess, I will pay 50 and the insurance will pay 50, but I have excess insurance. So I will, the excess insurance will pay for the 50 million and the umbrella, it's other 50. So the general liability had an 150 million coverage in each level. And really, if the insurance company making a contract according to having an excess and umbrella, the premium each month will be increased. So the other thing in the contract, other than the layers, the excess and the umbrella, if there is available in our insurance or not, it is the insurance contract, the condition of limit of liability, such as it's per occurrence or aggregated per year. Is there is deductible or not deductible? So deductible, like I said, it's amount of money, it's get paid by the organization before the insurance company get interfere. The other thing is insurance coverage type. Which type? It's a claim-made coverage or occurrence coverage. And in a simple way, we have to know that the occurrence coverage, there is a policy, there is inception date and expiration date. Let's say that's from the 1st of January 2020 until the 30th of December 2020. This period, anything that's happened in this period and get reported in this period is covered by the insurance company. So if it's happened in this period, but it's incurred but not reported, as there is an IBNR, it's incurred but not reported. It's reported after this expiration date, the occurrence coverage, the insurance company will cover this accident or this claim. But while the claim-made coverage is not, if this period it's end and there is a complaint after the expiration date, it couldn't be covered. So I have one of each way to do it, either to do a tail, so it's extending the reporting period, or I do a retroactive date, so a retroactive date that can cover all the period from the inception date under the date that the incident is reported in. So the claim-made versus occurrence policy, it's two different. The occurrence policy have an having a high premium rather than the claim made, because there is an open reported date, open reporting time, while the claim made, I have to go for a tail coverage or a retroactive date with a nose. The nose is the period from between the insured retroactive date and the current policy period. So we know now about the type. Of the coverage type in the insurance contract. Now I will talk a little bit about the regulation of insurance. The regulation of insurance, it's really a financial strength and size, having a very, very huge companies and market for this type of business, the insurance. There is a hard market and soft market, and the hard market, it's really difficult than the soft market, and everybody like to deal with the soft market, because the hard market having a strict underwriting standard, reduced capacity, fewer competitors, higher premium, and restricted coverage. While the soft markets, it's easier underwriter, there is increasing in the capacity, more competitors, low premium, and the broader coverage. So the soft market, it's easy to deal with, while the hard market, it's difficult to deal with. But in some cases, we are in need for the hard market. It's other than the healthcare organization. In this regulation, there is an insurance purchasing, and it's between agent and the broker. And the agent, it's the one who is in the insurance company, while the broker, the one who is in the organization. So to know how to do the contract and how the underwriter is evaluating everything, we have to know some definitions, such as underwriter, actuary, claim adjuster, claim examiner. And those four is working in the insurance company and dealing with the IBNR, the insured but not reported, and the stop loss. So the underwriter is the first person visiting the organization to evaluate the risk the organization have. And then the actuarially, there is a person from the insurance company to evaluate the financial cost of risk and estimate of expected loss and dollar set aside for a future and possibility of the self-insurance retention. So the actuary and the underwriter is a very important person for the insurance company to evaluate this organization. Is it suitable to make a contract with them or not? And then the actuary have an accounting applications. I will not talk about it this time. I hope that there is other time to talk about it. While the claim adjuster, the one who's doing the investigation when a harm it's happened or any occasion it's happened and need the coverage. So the claim adjuster is going to the organization and evaluate, they are doing a negotiation settlement, and are we doing a negotiation settlement, or no, it's not a need to even to cover this occasion because it was because of the careless of the organization. The organization didn't take any good precautions to prevent this occasion to happen. So the claim adjuster evaluating the occasion itself. Is it worth it to be covered or not? And if the claim adjuster can't manage the situation, so the claim examiner interfere. What is the IBNR? It's incurred but not reported. I state that, and sometimes there is occasions happen but not reported, and it's reported later on. So to be covered, the claim examiner or adjuster have to evaluate the contract. Is it a claim made or occurrence made or occurrence coverage? So according this are main things to evaluate they can cover it or not. And finally, the stop loss. It's discovering in this company or this organization can it change from the insurance to self-retention. So it provide the coverage in a large loss, step in for insurance company. Actually, I'm a self-retained or I'm self-retention company organization. I'm financial retention. Financially, I'm retained the risk retention, not risk transfer, but in some limit with a large loss, a very huge loss. I stopped. I can't funding this loss, so I step in for an insurance company to come and evaluate my situation to create a contract with me. So finally, because I'm ending my lecture, actually the lecture is it's very huge and there is a very huge information, but I try to summarize it as much as I can to fit this 1 hour. There is something called request for a proposal from the organizer. We know that in the insurance company, they have an underwriter, actuary, examiner, and the adjuster, the claim adjuster and the examiner. Now, from the organization, I have to send some people to deal with those people of the insurance company. The risk manager is one of those people, and the broker. Actually, there is a market proposal and conceptual proposal to request for a proposal for a broker to deal with the insurance company workers as underwriter and actuary. This is the last minute. Thank you very much. Hoping everybody enjoy it, and really I'm ready for having any question.
Allah يكرمك يا دكتورة يا رب. Thank you so much, دكتورة سحر. Believe me, you managed to compact in 1 hour so much knowledge, and this is also very fundamental information about this big domain of health risk and insurance. We look forward in the future to arrange with you, giving a whole training program in this. This will just an appetizer for us.
I'm glad for this, Doctor. I'm glad for this, wallahi.
Why the categories of risk started from E to I and not from A?
No, it's actually started from A, but the one that in the healthcare management that we are dealing with events, it's from E, when there is a temporary harm. Like before the temporary harm, it's near miss. It's almost reaching the patient, but it's not happened.
I see. The other one from Riyad Karim, he's asking, in calculation of the risk, on which base we grade the impact?
Yes, the impact, there is likelihood and impact. The impact, there is different type of impact. As I said, there is so many things. Each one, it's from 5. We accumulated, okay, plus it each to other, and then we get a number and multiply it with the likelihood. I will go back to it. Yes. So financial, I have 4. Patient safety, I have 3. 4 plus 3, 7. Here 2. 7 plus 2 is 9. 9 plus 1 is 10. And then the total one, we multiply it with the likelihood.
I see. Abra is asking why we have class in human insurance if everyone should be treated the same.
A class in what?
Human. Do you have a class for human in the different classes you mentioned?
No, it's not the human here. It's meaning the human capital of the organization. The loss of the loss of the career. The patient. It's not loss of a career. The fired, they get fired. The turnover in the recruitment turnover.
MashaAllah. Also, Abra is asking in health issue, if nurse or doctor made mistake, who can find out of this mistake or error and how? In United States, the insurance do the investigation for the claim.
Okay, actually, this certificate is talking about the CMS, the Medicare and Medicaid system in the state. Okay, so they are trying, and there is really a prizes for the organization who's making a transparency and really applying the justice culture in them. Actually, who did the mistake have to report, and this is they really supporting their doctors and nurses and the staff to report each error, because when you report it and it's unintended, there is no punishment. But if there is reckless behavior, there isn't a punishment.
I see. In fact, the first question was posted by Dr. Muhammad Khurshid Akhtar, mashallah, at the very beginning of the lecture. He was asking what are the critical or most important risks and opportunities in process in insurance regulation in healthcare. Is awareness of insurance regulation necessary before implementing it in any healthcare services?
Yes, sure. An insurance company is there because of the risk. When there is a risk, you have to be covered by insurance company. So we have to be aware about the contract, about, the insurance company. It's really in the declaration page. If there is award is missed, it's kind of changing all over the contract.
Oh, I see. In fact, in the chat, we have tons of people who are sending very good words, thanking you for a very impactful presentation and very enriching one. And كلهم الله يعطيك العافية. Thank you so much. بسم الله ما شاء الله.
شكرا لك دكتور. والله أنا صراحة محرجة إني أكون قدام حضرتك والله بس.
العفو يا ستي الله يبارك فيك إزاي. Last question from Hassan. He's asking, in the USA, doctors or physicians have to do insurance to cover their mistakes.
Yes.
However, we do not see it in the kingdom. So does the doctors have to buy insurance for themselves?
Yes, we have. No, it's in the kingdom. We have a medical insurance liability. اللي حينتهي عندي, it will expire after 7 days. I have to renew it. No, we have to do it, and even it gets increased according to the specialty you have. The surgeon is different than the dentist. The dentist is different than the nurse. No, there is a medical liability.
MashaAllah. طيب. This, in fact, brings us to the conclusion of this webinar, Dr. Sahar. But we, in addition to thanking you so much for giving your time, and I can imagine how much time you have spent in preparing these slides and putting them in such concise way. And your presentation skills was very fluent and, mashallah, very impactful. And we look forward, as I mentioned earlier, inshallah, to have more opportunities. In fact, it's an opportunity. We have almost more than 400 people attending the webinar. In fact, this is the highest registrations, attendance as a proportion of the registration that we have ever had in GPMA webinars before. Usually 1,000 people sign up, 200-300 people show up. In your case, 500 people signed, 400 people showed up, which is 90% show up rate, which is, mashallah, very good. In fact, if any of the participants is interested in having further training and programs in the area of risk and insurance in the healthcare sector, please, just drop us a note in the chat, and we will make sure that we can put together a program, and we will update you and let you know. Everyone will receive an email, inshallah, most likely tomorrow morning or the day after tomorrow, which include the link to the video recording. And if Dr. Sahar allow us, to share the slides, we will share the PDF slides, inshallah. So if you can just put it together and send it to us, Dr. Sahar, whatever slides, we'll be very happy to share it with the participants because many of them have asked for this.
Sure, Doctor, sure. تحت أمرك.
Inshallah. The other thing that many of the participants are asking for ساعات اعتماد, you know, and I would like to take this opportunity to ask all the participants, especially those working in hospitals. We cannot get ساعات اعتماد unless I think we coordinate this with one healthcare provider through a hospital. We have to do between a training center in Saudi Arabia and a hospital. So we need your support in order to get recognized, you know, recognition from هيئة التخصصات الصحية, the board, for giving you credit for this, you know, attending this webinar. Anybody who attended today's webinar, the information is stored in Zoom. When did he logged in, logged out, how many minutes he stayed? Whoever spent 40 minutes or more, inshallah, can get a certificate. How you get a certificate and what's the process, the information will be included in the email that will be sent to you, inshallah. And if anybody can help us in getting the recognition for this training hour, اعتماد هذه الساعات, we will be very grateful to you. I would like to conclude with that next Saturday, we will have a training program which cover course number 1 and 2. The cost for this course is $1,000, but we have an opportunity for you to attend this for free. You don't pay anything, totally for free. So the training program, which costs $1,000, you can get it for free if you participate في مسابقة, scholarship. It's a competition. We will offer 4 seats for free for people who participate in this competition. What you need to do is to search in the internet or in your organization. If you have a strategic plan, you send us a copy of the strategic plan, and we selected 4 types of organization, either a hospital or for a school or for a charitable organization or for a government organization. Search for a strategic plan, an integrated one with all the analysis, objectives, strategy map, KPIs, dashboard. If you can send it and share it to this and send it to this number, please, Ahmad or Ahmed, put this number in the chat. So whoever would like to participate in this, tomorrow evening, which is Wednesday evening, is the deadline. So by this time tomorrow, it will be the deadline, 10 o'clock, exactly tomorrow after 24 hours. It's a very easy competition to participate in because you don't have to develop the strategy. You just need to share whatever strategy, and we will select the best, you know, the best 4 submissions. And the remaining people who may not have the opportunity to win, inshallah, with you, we can give a significant discount up to 25% just for participating in the competition. And please, GPMA team, if you can put information about this in your strategy. Dr. Sahar, again, thank you so much for your time, for your beautiful presentation. I am sure that this presentation will remain on our website, in our YouTube channel for many years, and many people will benefit from this. And Allah subhanahu wa ta'ala, we pray that Allah subhanahu wa ta'ala will reward you for this as a perpetual charity, صدقة جارية وعلم ينتفع به.
شهادة أعتز فيها والله دكتور، أنا شهادة أعتز فيها، وشكرا لك، وتشرفت والله بحضوري، وتشرفت بحضور الجميع يا رب، يعني يعطيكم، فأنا تحت أمركم بالتوفيق.
Yes, few people has asked for your contacts. Thank you very much for taking this initiative. Anybody would like to have direct contact with Dr. Sahar, she's too kind, to share her email, and inshallah we can keep in touch with her.
Business.
Thank you everybody for being with us. Jazakumullah khair. In fact, for the remaining of the next 3 months, September, October, November, every week, every Tuesday, we have a webinar. Tomorrow, in fact, we have a graduation presentation. One of your colleagues who completed all 10 courses, Alhamdulillah, he completed the 10 courses and he prepared his graduation project. Tomorrow is his graduation project defense, and he has to do the presentation in public. And you are all invited to attend. We will put the registration link as well in the chat. غدا في أحد الزملاء استكمل بنجاح دراسة ال10 كورسات، وسيحصل غدا إن شاء الله على شهادة الخبير الدولي المعتمد في التخطيط الاستراتيجي وإدارة الأداء. لكن للحصول على دي الشهادة لا يكفي النجاح في ال10 كورسات، يجب أن يعد مشروع متكامل لخطة استراتيجية ويقوم بعرضها علنا. وفي لجنة تحكيم إن شاء الله هتكون موجودة غدا، اللي يحب يشترك معنا بكرة الساعة 9 أهلا وسهلا به. شكرا جزيلا لكم والسلام عليكم ورحمة الله وبركاته.
شكرا دكتور.